All right, well, certainly, I thank you for the opportunity to being here and being part of this community that we all celebrate and cherish. And I think Cecil and I did internship together quite a few years ago and have had a bond over the years, not just academically, but as friends and in Christ, as brothers that we celebrate being part of the Mayo community. Pediatric cataracts, and my sense for most of you in the room, does anyone do pediatric ophthalmology consistently? Okay, a couple. Part of the attraction of these meetings is most people I don't go to retina meetings, or even when there's at the AAO, I kind of go to the ped section. Or for those of you that go to the retina sections, you probably don't go to spend too much time in the peds rooms. And yet there's certainly these opportunities, meetings like this, that we come together that we can share and a little bit about our practices to help each other appreciate what's going on. Whether it's someone in your practice that you get to ask a question that's outside of your range of interest or field, or whether it's you're serving in a place and you're asked to help care for a patient that is a pediatric cataract, and you do adult cataracts and you want to know, well, maybe I should try this. Here I am in Honduras or wherever you are. So I just want to talk about some techniques or awareness that we have in pediatric cases, and where it currently stands in our and how your care might change wherever you practice. So next, the slides are presented here. There we go. So I have no particular financial interest to disclose with this talk. IOLs in children are still off-label in the United States, but it's in a good practice that we use them, or standard practice. And certainly I think people realize that congenital cataracts and all the anomalies that go with them are complex and pose different challenges depending on the age of the child and what we find. Just to talk through the different literature behind pediatric IOLs, I think most people recognize that we use them in kids. How young do we use them? It depends on your practice, but for sure, most people after age 2 now, it's standard of care. Most of us that are in pediatric ophthalmology use them down into the first year of life. I'd say that people that are fairly high-volume cataract surgeons now, somewhere between 6 months and 15 months is where that transition is, depending on the child, and we'll talk about why. So I'm going to group and talk about just some of the techniques for success, meaning when do we use a lens, into these different age groups. And I just want to highlight the literature. What does the literature say on IOLs in infants, defined in the first 6 months? In toddlers, defined as 6 months to 2 years. In young kids, 2 to 7. And then older kids, 7 plus. So when you look at these a lot of the advances in the last 20 years have come into big registries and multi-center studies that have helped us define the risks at different age groups. And so in infants, we have this thing called the Infant Aphakia Treatment Study. If you picked up the Blue Journal or JAMA over the years, you realize, that ITS, another one. It's probably published 60 or 70 articles now on this group of kids. Soon after my fellowship, 20 plus years ago, I was asked to be an investigator. I was opportunity, so I've been part of the ITS over my career, and then I've had a couple other registries and things I've been involved with. Toddlers and infants, there's a number that have been done, and then the toddlers only. And the reason I kind of highlighted this is the younger the kid, the bigger the risks. And so when you look at outcomes in different age groups, you have to keep in mind whether or not the higher risk kids are included with lower risk kids. And as I have underlined here, the first 6 months have the greatest risk, and we'll talk about what those are. As the older kids get, I'd say 6 months to 2 years and beyond, the risks drop meaningfully. The next older age group, this sort of up to age 8 years, there's 2 big databases that have helped us define care. One is PCare, that's out of Sweden in Scandinavia, and the other is PDIG. PDIG is just starting to publish their 5-year outcomes. The first is just released last year, and there's more coming. And then the STORM, Ed Wilson, looked at ages 2 to 7 year olds. So the data I'm going to share with you comes from these big registries. All right, where do we stand in vision? How do kids do after cataract surgery outcomes with IOLs or without in young kids? And most of these registries and single studies would share that IOLs do not help your outcomes provided you have good contact lens care. And that's where there's been a shift back that we started to use IOLs more and more and more in the early 2000s, even in infants. And people thought, oh, we're going to help the vision outcomes. No. If you have access to contact lenses, even in a 4-month-old, generally speaking now, we go back and we put contact lenses in those kids and we let the eyes grow up. And then later do a secondary lens. But as the risks drop, the use of the IOLs go up. So the vision outcome, though, it really doesn't matter. If you have good contact lens support or aphakic glasses or IOLs, you do not worry that you're in a lesser category of vision outcomes. Certainly bilateral cases do better. I think we all know amblyopia sucks. If you have something wrong in one eye, you can address that issue, but the brain always likes to shut it off. And so unilateral structural abnormalities not only have an issue with the organic disease itself, but also the physiologic development of vision being denser, where a child with bilateral cataracts can have it addressed beautifully and develop really excellent outcomes. This is in the recently published PDIG data, looking at children at different age groups, and unilaterals, as you see, have less visual acuity outcomes than bilaterals. And that's just, summarized by this slide. All right, but what it really comes down to is risks. We can put lenses in kids, even a 1-month-old, and have a beautiful outcome with an IOL and optical correction, but the risks are higher. And I just want to touch on these because if you get into the pediatric population, your techniques need to change potentially to help to mediate these risks. Certainly complications, iris prolapse and capsular rents. If you've torn rhexis in kids, even iris, the wound integrity, it's different. And if you're not used to that, just be aware as you get into the younger age groups, the techniques can change to stabilize the chamber. The biggest thing is adverse events post-op. Corictopia, maybe not that important for visual outcomes, but membranes, cortical regrowth, and the big actor, glaucoma. Refractive surprises, obviously when you're doing contact lenses, you can keep changing the contact. But if you put a lens in the eye and the eye's growing in axial length, you're going to know you're going to either generate a refractive error over time or you need to aim for hyperopia and let them grow into that lens that's inside their eye. All of these things can lead to different reoperations. The landmark multi-center study, randomized study, was the infant aphakic treatment study in infants. And that compared contact lenses to IOLs. And if you know, over the last 15 years, we've shown that when you put a lens in an infant, it's going to have a harder time to avoid these adverse events. And what are they? The biggest things is lens reproliferation into the visual axis or some level of opacity. That can be membranes from inflammation. It can be capsular phimosis around the lens. Or the big thing to be aware of is the cortex regrows. So you clean out the lens, you suck every little bit, capsular polishing everywhere in an infant. And you come back later and it's like, look at the big chunk of cortex because it regrew. These pearly stuff regrow and they grow across the lens. Anyone that's seen an infant grow up and you see it as an adult and you dilate them, what's back there if they've been left aphakic? A big ring, we call it Sommering's ring. It's an inner tube of white material. Why? Because the cortex regrew, but because they left it aphakic, the ring sealed to itself, and the anterior and posterior circular opening sealed, but inside that sealed ring regrows cortex, and you get a Sommering's ring. So, when you look at the infants, we're talking about infants have higher risk of IOLs, and the older you get, the less the risk. I help to lead TAPS, which is a registry group, and you see here the risks start dropping meaningfully. In particular, look at the bottom line, glaucoma. Glaucoma related to infant or childhood cataract surgery is really in the first 6 months. The older a child gets, even 2 to 7, the risks drop. Now the glaucoma is on the second to bottom line. The PDIG study that was just published or is being published, would show that even in childhood, there is potentially ocular hypertension or glaucoma suspect, and rarely a glaucoma that can be attributed to cataract surgery. But when we talk about aphakic or pseudophakic glaucoma in kids, be aware it's in the first 6 months. So if you care for children, do infant cataract surgery or manage them, always know the elephant in the room is, does this child ever get glaucoma? And the rates here are, in IATS we're 10 years out, but these children have a long time to grow beyond that. Visual axis opacifications drop, strabismus drops, all these risks drop, but these are not eyes that are easy to manage, and certainly the consent of cataract surgery in children needs to reflect that. Bilateral is the same case. All right, let's talk about them specifically as you manage them. So, adverse events are higher the younger the age. Doing a cataract surgery in a 5-year-old, fairly straightforward. Doing cataract surgery in a 5-month-old, there's a lot to talk about. What do we know about visual axis opacification? How does your technique potentially change if you're doing a capsule procedure on a 5-year-old versus a 15-year-old or a 1-year-old? And just the comments here on the capsule opacity can regrow the cortex, the phimosis. And most studies are with acrylic lenses. And most studies historically do not involve optic capture, which I want to talk to you about. This shows that as kids get older, the difference between placing an IOL versus aphakia. Aphakia we talked about, Sommering's ring. They lock down together so cortical regrowth doesn't get back into the visual axis. Throw a contact lens on the kid and the kid does fine. There are some that still opacify, but universally when you put an IOL in the bag, and the anterior and posterior capsular leaflets can't fuse, what happens then is any cortical regrowth comes across that lens, the inflammation from the cortex gets across that lens, and there's a higher rate of reoperation, even in a 3-year-old because of these risks. So what's happened over time, this is the PEDIC study. Oh, let me go back. The incidence of surgery to clear the visual axis, and at all ages, you have to talk to families about you may have to go back and clean off that lens for some reason. It's an important part of your consent process in kids. So what can we do differently, or what do we do differently now versus 10 years ago? And the big thing is optic capture, and or at least opening the posterior capsule at the time of surgery. We all know that in adults we have to do YAGs. Well, I'll tell you, it's so depressing when you get a great result in a 4-year-old, and then a year later you got this membranous anterior capsule and you're yagging the thing and it doesn't want to clear very well. I'd say pediatric ophthalmologists now sometimes primarily open the posterior capsule, even in 11, 12, 13-year-olds, because we just want a clarity and stability over time. So, first and foremost, in terms of managing this visual axis reopacification, is it's a beautiful result to just leave it aphakic, let the rings fuse, as you see in the bottom behind the iris, and come back later, setting the stage for a secondary lens. And this would be an example. I just did this case a week ago. And how do we get that to play? Nope. They do play somehow if you click on them. I should have done it automatically. But here's going in years later. This is a child, 11-year-old, Sommering's ring. I open the ring back up with an MVR blade, 3 different incisions, just going in and kind of sawing, respecting the posterior capsule surface, but going into the inner tube and opening up the inner tube of Sommering's ring, sucking out the chocolate. I call a lot of times when I describe lenses, I describe it like a plain candy M&M. In this case, you're sucking out the inner tube material, and you can replace a lens back in the bag, or into the bag, or in the sulcus down the road. My videos may not be playing, but it's all right. So number 2, if you are placing a lens in a 3-year-old, I want you to think about starting to consider posterior optic capture. Why? We talk about the capsules changing, cortical regrowth, different opacifications. So when you place one in the bag, or when you place a lens in the bag, it again normally would vault the anterior posterior capsules open. But the shift has been in peds is either place a lens in the bag, open the posterior capsule, and then you can tuck the optic behind the posterior capsule with the haptics in the bag, Or the thing now that more people are doing less than age 2 is you take a 3-piece, throw it in the sulcus, and if you've opened up the posterior capsule or anterior capsule, open up the posterior capsule and you tuck it through both. So you do a double optic capture. The haptics are in the sulcus and the optic is through both, allowing the rings to fuse. And it allows you dramatically reduce the reopacification that can happen in kids. You reduce the inflammation because you're not keeping cortex exposure open. And that's what's changed, I'd say, since a lot of these studies came out. This is Howard Gimbel first described capture. People are aware of that. On the right, is there a way, you guys use your slide over and click on the video on the right? Anyway, this is an IOL that's in the bag. These all should be playing, and so I apologize. But it's an IOL in the bag, a 3-piece, and I tuck one side and tuck the other side. For those of you that have done optic capture, can you hover over it and click it? What? Okay. All right. So that's not so much fun, but that's all right. So you're tucking the optic behind the posterior capsule. I'm going to try to go forward, but now I can't. There we go. So certainly when a YAG is not feasible in a kid or when there's a questionable, take the time and open the posterior capsule. It's not a problem to put a lens in the bag the standard way and then go behind it if you have a cutter, and usually pediatric ophthalmologists use vitrectomy oftentimes, and just make a small posterior capsular opening and a small anterior vitrectomy and come out and be done. The alternative, a lot of times around the world, people are doing is they tear a posterior capsulotomy. Don't disrupt the anterior vitreous face, just a small little nick, put some Helon underneath that posterior capsule in front of the anterior vitreous face, and you tear the posterior capsule and you have a clear visual axis with the lens in place, whether you're putting the lens in after that step or before, which I favor do. So people are opening the posterior capsule more in kids now and doing some sort of optic capture. Certainly, if the child's old enough to do a YAG, it's fine to do that. But know that it's commonly, even though some of those kids have to go back to the OR at times. Instruments improving success, the biggest thing is microforceps. I'm sure you have aspects of this. Intraoperative OCT has been helpful, and certainly intraoperative drug delivery. I'll touch on that in the end. Here are my forceps. These are supposed to play, showing the rhexis opening, and these small incision openings, opening the anterior capsule, and these are the same techniques if I'm doing posterior capsule. Open. This was again a technique over how you can change your capsular size after the lens is in, going in with an MVR blade and stabbing the anterior capsule and then tearing it slightly bigger. It's hard to do that in adults. And then the techniques that some of you are aware of, I think there's even a display out here over using diathermy. Again, this video won't play, but this is a tough persistent fetal vasculature eye, and a lot of times we use cutters, but there are times diathermy helps to actually just cut the membranous traumatic or PFV openings in these eyes. This was a diathermy case of taking it in there, going right around the anterior capsule and essentially carving your anterior rhexis. Not needed, but an option. I'm so sorry that some of the videos aren't playing, but this was in the bag and the lens. Dr. Tazignon in Europe, we don't have this lens in the United States, but does an anterior capsule and a posterior capsule and has a lens that goes in and has a leaflet. It's like two planes with these arcs that stick out, and it allows Sommering's ring and sort of holds itself into Sommering's ring. If you're aware of that lens, it's kind of a new one. All right, so the biggest changes I just want to encourage you about, the younger you go in kids, understand posterior capsule is going to opacify, and you may want to open the posterior capsule primarily and tuck the optic as an option. Number two, the second biggest takeaway from this talk is meant to be understand the importance of monitoring for glaucoma, and understand that now pediatric ophthalmology is shifting the age groups potentially. The younger the age, the higher the glaucoma. We talked about that. The use of the IOL does not change glaucoma rates. But the younger the age, the more the glaucoma. And obviously, microcornea, small little eyes, potentially higher. I'll just one comment on that. We all recognize that if a child's born with a unilateral cataract, you've got to get that thing out to help the vision develop. But it's been proven for decades that we do not need to be taking the vision development, just like if the baby would have stayed in mom another month, they would have developed good vision even if she's post-dates. Leaving the cataract there for a matter of weeks does not hurt your visual outcome later. There's a certain point thought to be in the second month where the visual outcomes start dropping because amblyopia starts hitting us. Even though at the same point the rate of glaucoma is going down, the rate of amblyopia goes up. And the question is, how long can we wait on a pediatric lens removal before the amblyopia bites us, knowing the longer we wait, the better our glaucoma outcome? I just did a case last week on a bilateral infant with microphthalmia and cataracts in the 3rd month of age, and I waited 6 weeks. The evidence would show right now that bilateral cataracts in an infant, you can make an argument that we have no data to suggest early surgery is better. In fact, no one should ever, in current data, be removing a cataract in an infant less than 1 month gestation. If the baby's born and 2 weeks later you're doing cataract surgery, you shouldn't be doing it because you're increasing the rate of glaucoma and there's no help to vision rather than waiting another month. So we're all learning how long can we wait knowing glaucoma is going down before we operate. Bilaterals are the biggest question. Unilaterals are probably in that 2nd month of life, ish. Bilaterals, I think the debate is, should we be waiting till 3 months of age? Because there's no good data right now to suggest removing it even as a month is better than 3 months. And we might be increasing glaucoma risk. So that's an ongoing conversation. Strabismus, very common, especially in the unilaterals, and be prepared to manage it. There is no benefit, however, known that operating on strabismus in a child after cataract surgery, unilateral, bilateral, helps their outcomes. So I usually now tell families, we're working on vision now. We're going to fix their strabismus later. When? School age, when it starts mattering. But even realignment of eyes does not appear to improve visual outcomes or amblyopia development. Refractive error is the biggest mess. These eyes grow in axial length dramatically, unpredictably, and our IOL calculations are flawed. So if you're putting an IOL in an infant and you want them to be the best chances of being plano at age 20, you probably need to leave a residual hyperopia of plus 12. Dramatic. Most studies would show, and then the first year, it's dropping. So by the time you get to about a year or two, not so bad. The rule of thumb that a lot of people use is the age plus the residual refractive error should equal 7. Now, this is not the first year of life because most of us don't. If you're putting IOLs in the first year of life, you're either, we should talk. And I do it sometimes, but not very often. But after that, say in a 2-year-old, pretty conservative target, leave plus 5. Don't aim for plano, aim for plus 5. A residual hyperopia. Age plus the residual hyperopia. In a 6-year-old, aim for a diopter of hyperopia. It's all okay. Now, people would argue that there's still shifts later, and so there are times where we leave a little bit more. But Laura and Yeti described that rule. Age plus residual hyperopia is 7. I have aimed for plano in a 2-year-old. Why? Because we're so behind the ball on refractive management, and I know the child's not going to wear glasses post-op. I don't care what the refraction is later if I can't get the vision better now. So a lot of times pediatric ophthalmologists don't leave that much hyperopia because we know we're behind the ball in amblyopia or we know we can't do refractive corrections. But if you know you have a compliant child, compliant family, wear glasses, that age plus a refraction of 7 is reasonable. All right, detachments happen. You might wonder, well, I don't want to open the posterior capsule and bite on the vitreous because I might get detachments. Yes, but very rarely. Pediatric vitreous is so tough, and especially if you are going to do vitrectomies with appropriate techniques, you don't get into trouble as much as you think. What's the statistic? Probably 1 in 200 kids get a detachment, but a lot of those eyes may have higher risk, excluding the Marfan group, but fairly low risk. As I talked about, the refraction is the wild card, and you need to understand why you're either aiming for something closer to plano or you're going to leave them hyperopic if you're placing the lens. And other tips, dropless. And a lot of us do intracameral antibiotics. I do intracameral Vigamox after all my cases. I don't always know if parents are going to be doing drops in kids. There are a variety of steroid outcomes. The younger the kid, the more I'll even do 1 week of prednisolone elixir. Oral prednisone elixir is a wonderful thing in pediatric post-cataract and actually after pediatric trauma. If you see an 8-year-old with a corneal laceration and capsular rupture and you got cortex floating in the AC and you're, oh, we got to do this, we got to quiet him down with drops and maybe we have to go to the OR, put him on oral. Prednisolone tastes better than prednisone, 1 mg per kg. They tolerate it great and it quiets everything down and lets you calm down the eye and operate on cataracts at a much more stable situation. Remember dilating some of these kids, and then even Diamox in certain situations. So, when to use an IOL in kids, it really depends on age, and the lower you go, the more you have to think about. And when standard lenses don't work, I'm done with my talk, so I just to say there are situations where we use, I'm just going to jump to the end here, aphakic lenses, sutured lenses, and or intrascleral, but those are nature for another day or another talk. So thank you for the opportunity to be up here, share a little bit of snapshot of our understanding of how management is changing in kids and how to mediate the biggest thing is visual axis opacification in the pediatric pseudophakic population.
What's the youngest age where you think a scleral fixated IOL is appropriate for a child?
Great question. I was going to show a picture. To me, and the Marfan situation would be an example, I really push contact lenses. Contact lenses should be the mainstay, or aphakic spectacles, for the mainstay of subluxated lack of capsular support in children. They're complex, but there are times where you need to put one in. Most of the pediatric ophthalmologists that are in this realm probably still lean towards artisan lenses, iris clip lenses, and you can talk about endothelial management. There's an ongoing study that a lot of us have our patients in looking at that. I've been putting those in for a decade, and I would say that it's still a viable option, knowing the risk of scleral fixation is over a 90-year child's life is concerning, knowing the eye is growing. I do think that Gore-Tex is probably our favored at Mayo and other places choice, and older than age 10 ideally. My worry about the hip, cool, I'd like to know how to do it more, but don't do it. Glued lenses, intrascleral tracks, is if you've ever done strabismus surgery, and I'm a pediatric ophthalmologist and a cataract surgeon in strabismus, if you've ever pulled up a scleral buckle, 30 years later, what does that sclera look like? It is paper thin. You can see the sclera or see the choroid. It's blue. Chronic material around the sclera changes the integrity of sclera over time. And my big question over intrascleral glued lenses is, in the life of that child, as the corneal diameter is changing, is there any at all, the wiggling motions, is there any haptic stretch that's trying to be bigger than the cornea, or is there any sense of the haptics pulling into the eye over time? And over 20, 30, 40 years, is that ever going to erode or undermine the integrity of the limbus structure in the quality for future trauma? And my worry would be, I don't think we know enough. And so at least where I am at Mayo, we've sort of shifted away, and we don't do intrascleral till they're at least 20 years old. Gore-Tex is our preferred choice in kids that you have to do one, but even at that, there's got to be strong reasons to do it less than age 10. And those come up, but they're atypical if you really have good contact lens care.